Hi there, my name is Anna Hyatt, and this is my patient presentation for OBGYN. This is a 27-year-old Russian Caucasian female who presented to the clinic for routine follow-up care and evaluation of her left ovary. She fears she may have a risk for ovarian tumors on her left ovary due to a personal health history that we're going to talk about a little bit more. She presented to the clinic as a routine follow-up visit. She was told originally that it was best practice to have her remaining ovary evaluated via ultrasound for early interventions if she is found to have concerning ovarian changes. The patient is a young married woman who recently came to the United States from Russia. She thinks she got her first period around age 12. What's interesting about her is when she was a young teen, she began to develop swelling in her stomach that she and her family attributed originally to teenage weight gain. And so after attempting to lose this weight and only finding her abdomen growing more and more distended and firm, she was taken to her doctor, and ultimately it was discovered that she had a large cyst adenoma, 10 kilograms, pretty sizable, on her right ovary. And so they did a complete oophorectomy of her right ovary, including the adenoma, and they used a midline open approach. The patient reports she was 14 years old at the time, which is pretty young. Since then, the patient has been placed on oral contraceptive to manage and prevent further tumor growth, and she has been receiving ultrasounds routinely every 3 to 6 months to ensure no new growth is occurring or there's any changes on her remaining ovary. To date, this therapy has been reported as effective, and there's been no concerning issues presenting in any of these follow-up ultrasounds. The patient reports she's been in good health since then, and she wants to preserve her fertility as much as she can, understandably. So the patient resides with her husband and states that she does become occasionally emotional from time to time. Since her surgery, she reports regular periods with heavy cramping for the first 2 days. There's 26 days between cycles and a 4-day menstruation period. She's never been pregnant, so G0, P0, A0, but she states she does really wish to have children. She's been on a Russian form of birth control, but then since she came to the United States, she was switched over to Yaz. And she's been maintaining a steady weight, and she stated no other significant health concerns. At the last visit, there was a concern expressed by the patient that she's been having some brown spotting while on the Yaz, as well as some mild to moderate intermittent cramping that she manages with ibuprofen. Review of systems, the patient has basically reported that she's been very healthy except for the spotting, and then she also had a recent dental exam and cavity filling. I can't think of anything else that she reported that was really remarkable. She did mention some mood swings that we're going to talk about a little bit more. Past medical history is pretty much negative for anything significant. Her last PAP was on 9/30/18. She reports a sexual history of 2 male partners in her lifetime, and one of those is her husband. She's negative for any STI history, and her immunizations are actually very well up to date because she had to get quite a lot of immunizations done to come to the United States. Other than that right oophorectomy back in 2005, she's had no other surgeries. Allergies, none, so no drug, food, or herbal allergies, and the only medications she's on are the Yaz and the ibuprofen, and otherwise she says no herbal supplements, no vitamins, nothing else is being taken. The patient has never smoked. She says she does drink alcohol occasionally, but states it's less than 3 drinks a month. She does drink caffeinated beverages, but she's not been counting how many. She's never used recreational drugs, and she has no drug abuse or drug-seeking behaviors. Social work and work history. Patient lives with her husband in an apartment, and she states that she has friends from the Russian community who provide her support. Her family speaks with her on the telephone via Skype. She's currently a homemaker, but she does have a bachelor's degree. She stated she does not know if she wishes to try and gain employment while in the United States due to the complex worker restrictions. She goes to the gym daily for Zumba classes. She actually spends quite a lot of her time at the gym, and that's her place where she gets a lot of socializing, and she uses it for exercise as well. And she says this helps manage her stress. She does attend church, and she has a church support group, which she goes to for spiritual care. It's Russian Orthodox. She stated she is eating healthy meals and follows health-seeking behaviors. She does not currently have an established primary care manager for her general health. Her father is living, and he is a smoker. He has hypertension and hypercholesterolemia, as well as chronic back pains and possible arthritis in his knees. Her mother is also living, and she has a family history of breast cancer, but does not have any breast cancer herself that the patient knows of. The mother may be positive for some depression issues. There's no reported health issues with the siblings and no reported medical history with the extended family beyond the known breast cancer that was on her grandmother's side. The patient stated in her culture, health information is not widely discussed, so there might be health issues going on, but just nobody talks about it. Physical exam, labs, and other tests. Normal weight, normal height. So weight was 127, height was 5'5", blood pressure was fine, pulse was fine, respirations were fine, oxygen was fine. The ultrasound report from her last visit showed no concerning ovarian or uterine formations. All organs were visualized and deemed to be appropriate for baseline, and there was no recent lab work. The last set of serum labs was taken in Russia prior to coming to the United States, and the patient said that on those labs there were no abnormalities, and her last menstrual period was 1/11/2019. On her physical exam, again, she was just a normal, healthy gal. There was nothing that really stood out very much. On her abdomen, it was soft and non-tender, non-distended. She didn't have any tenderness while we were palpating. Bowel tones were positive, and she didn't have any concerns there. There was that midline scar from her surgery. She's continent of urine. Skin looked good. All cranial nerves appeared to be intact, and she didn't, even though she reported having depression or some sadness, she didn't appear to be in distress, and her emotional responses were appropriate. The ultrasound demonstrated good visualization of the left ovary and uterus, and what the doctor wrote, or what the report was normal endometrial stripe type 1. The right ovary was not visualized, obviously, because it's missing. The left ovary dimensions were 3.1 centimeter by 2.7 centimeter, with approximately 5 follicles visualized at varying sizes, which is very normal. The largest follicle was 7 millimeters with appropriate distribution of the smaller follicles. Cul-de-sac was deemed normal. So, in other words, a very normal appearing ultrasound for where she's at. Assessment showed no changes in her reproductive health status, and the plan is to continue to have the patient take her daily oral contraceptives to manage her cycles and possibly reduce the frequency of the ultrasounds, as there's not been any concerning masses or changes since the original surgery date. And so she was discharged back to the community. So for differential diagnosis, obviously ovarian tumor, pregnancy, malignant tumors of the uterus, and endometriosis. Actual diagnosis was generalized abdominal pain for the cramping. Follow-up care, she's going to continue to take her daily Yaz and follow health-seeking behaviors. She does have a prescription for Yaz written out for the next 6 months, and unless she begins to experience any symptoms or changes, they told her she didn't need to return to the clinic for further assessment or workup until the next 6-month evaluation, which is routine. They really discussed having the patient establish care with a routine primary care manager, and they feel this will be beneficial in the long run to the patient in the event that she needs further comprehensive health care while she's living here in the United States. And it may also be really helpful if she does experience depression symptoms or feels her emotions are exacerbating, because, again, this is a women's health clinic. They can't really do a whole lot for psychological follow-up. The patient is currently stating that she does not wish to pursue pregnancy at this time, but she does state that she wants to start a family at some point. And while there is no reason to assume the patient may have difficulty conceiving given her age and her overall health, the fact is she is missing an ovary and has a history of tumors, which may potentially have an effect on her fertility. So the patient may want to talk to her husband about when they want to start trying to have children and get pregnant, and possibly even speak to a fertility clinic in the future about their risks and optimal timeline for safe conception. So evidence-based practice, evidence shows that cyst removal surgery does not seem to impact fertility of most women like we talked about. So this is good news for the patient, as she does want to have children, and she has a reasonable expectation that she can conceive children using natural methods of conception. So if she decides she does want to proceed forward with getting pregnant, there's nothing standing out saying you can't do that, that it's out of the realm of possibility. Given her European genetics, data does show that the patient's current fertility rates are going to be at their most optimum between now and age 31, with a decline in fertility trends starting around age 32. So given her that she does have this desire to start a family, it's pretty reasonable to advise her to start a conversation with her husband about family planning and when they should start trying to conceive, especially if she's going to want more than one child, because you don't want to start trying to have your first child at the very end of your fertile cycle of your lifetime, and then you want to have a second child and suddenly you're 37. Yeah, you know what I mean? While the patient expressed concerns with emotions and wondered if this was related to switching to Yaz, it really is more likely that her emotions are exacerbated because of psychosocial issues, being in a new place, not having her immediate family close by, life stressors. So more than likely that's due to this scenario versus switching contraceptives, because just the evidence base shows that the Yaz and the birth control that she was on previously are pretty similar, and she wasn't having issues on that other birth control. There is a known correlation between ovarian cysts and a risk for breast cancer. A diagnosis of ovarian cysts is likely an indicator of hormonal milieu, and thus it may be related to breast cancer risk. So again, she does have that family history of breast cancer, so it might be a good idea to talk to the patient about her breast cancer risk, making sure she's doing self-examinations, and then when she gets a little bit older, really making sure that she's established with primary care so she can get mammograms if she's going to be in the United States later on in life. And then socially isolated young adults do not necessarily experience loneliness. However, those who are lonely are often depressed, understandably. So while the patient is presenting to the clinic for gynecological care, it's not unreasonable to assume the patient is experiencing some degree of loneliness in this new environment, and she's still trying to adapt. The patient has a follow-up visit in 6 months, and so making a plan to assess her mood swings and depression levels at her next visit would be appropriate. And so it's a good thing to follow up and make sure that she does have her primary care manager in place, and that she's continuing to pursue activities and fun things with others to help her stay active and well socialized. And so in conclusion, at the end of the visit, a follow-up visit date was scheduled, and the patient was satisfied and in agreement with the plan of care. If the patient's symptoms worsen before the next visit, she is to call the clinic or go to the ED immediately. The patient is to establish care with a primary care facility and schedule a new patient visit. She did have insurance, I forgot to mention that. And the patient is to continue to pursue health-seeking behaviors and speak with her husband about their future reproductive plans and maybe come up with a good timeline for when they want to start having a family. And then the patient was discharged back to the community. So thank you very much for listening to my presentation. I hope you found it helpful, and please feel free to make any comments.